मेरो आवाज सुनिरहेछ सबैजनाले? I see a thumbs up. नमस्ते सबैजनालाई धन्यवाद आज आइदिनु भएकोमा आज चाहिँ हाम्रो 20th नेपाल मेन्टल हेल्थ रिसर्च वेबिनार सिरिज मा सबैजनालाई स्वागत छ। मेरो नाम सवादा राई, म चाहिँ रिसर्च साइन्टिस्टको रूपमा काम गर्छु एट द सेन्टर फर ग्लोबल मेन्टल हेल्थ इक्विटी एट द जर्ज वासिङटन युनिभर्सिटी। आजको हाम्रो टपिक चाहिँ एकदम इन्ट्रेस्टिङ टपिक छ, जहाँ चाहिँ हामीलाई जोइन गर्नुहुँदैछ डाक्टर सगुन बल्लभ पन्त। उहाँको इन्ट्रोडक्सन चाहिँ पछि डाक्टर ब्रान्डन कोटले गर्नुहुन्छ। सो आजको टपिक चाहिँ dual diagnosis and stigma among service users in opioid treatment program, research needs in addiction medicine in Nepal भन्ने चाहिँ आजको टपिक चाहिँ छ। सो मैले अघि भने इन्ट्रोडक्सन पछि डाक्टर ब्रान्डन कोटले गर्नुहुन्छ, तर त्यो गर्नुभन्दा अगाडि चाहिँ कपल अफ हाउसकिपिङ थिङ्स बिफोर वी गेट स्टार्टेड। पहिला चाहिँ हाम्रो वेबिनारको बारेमा चाहिँ छोटो मिठो भन्न चाहन्छु। यो चाहिँ हामीले चाहिँ एभ्री मन्थको चाहिँ थर्ड विक चाहिँ हामी रन गर्छौँ। इङ्ग्लिस मन्थको चाहिँ थर्ड विकमा चाहिँ रन गर्छौँ। सो वर्षमा चाहिँ 12 चोटि चाहिँ हामी चाहिँ यो रन गर्छौँ। अनि यो चाहिँ हामीले चाहिँ टिपिओ नेपाल अनि द जर्ज वासिङटन युनिभर्सिटीको सेन्टर फर ग्लोबल मेन्टल हेल्थ इक्विटीको कोलाबोरेसनमा चाहिँ हामीले चाहिँ यो वेबिनार चाहिँ रन गरिरहेको छौँ। अनि हाम्रो मेन एम यो वेबिनारको भन्नाले चाहिँ अर्ली करियर रिसर्चर्सहरूलाई चाहिँ एम गरेको छौँ। सो डिफ्रेन्ट स्पिकर्सहरू डिफ्रेन्ट टपिक्सहरू ल्याएर चाहिँ हामीले चाहिँ डिस्कसन गर्छौँ र साथसाथै यसमा चाहिँ हामीले नेटवर्किङको पनि काम गरिरहेको हुन्छौँ। एकअर्कालाई चिन्ने, त्यसपछि नेटवर्किङ गर्ने अनि अगाडि बढ्ने काम पनि हामीले चाहिँ गरिरहेको हुन्छौँ। एभ्री वेबिनार चाहिँ हामीले डिफ्रेन्ट युनिक टपिकमा चाहिँ हामीले गरिरहेको छौँ। अनि इफ देयर इज एनी topic that you are interested in or any speaker you want us to bring us in, so please let us know and we will try to do that. अर्को चाहिँ हाम्रो डेट्सहरू अनि स्पिकरको डिटेल्स अनि कुन वेबिनार आउँदैछ भनेर चाहिँ तपाईहरूलाई चाहिँ इन्भिटेसन इमेल्स आउँछ इफ यु आर सब्सक्राइब। सो अनि साथसाथै हाम्रो चाहिँ ट्विटर, फेसबुक अनि इन्स्टाग्राम पेजहरू पनि छ। अनि त्यहाँ चाहिँ तपाईँले चाहिँ यो इन्फर्मेसनहरू पनि अगाडि चाहिँ पाउन सक्नुहुन्छ। सो फर सब्सक्रिप्सनको लागि चाहिँ हाम्रो इमेल सब्सक्रिप्सनको लागि चाहिँ हाम्रो मेरो कलिग रितिकाले चाहिँ इमेल च्याट बक्समा चाहिँ डिटेल्सहरू पनि पठाउनुहुन्छ। सो यु क्यान जस्ट गो हेड एन्ड देन सब्सक्राइब फर आवर इमेल्स एज वेल। सो अ कपल अफ हाउसकिपिङ थिङ्स अगाडि कतिजनाले नोटिस गरिरहनु भएको छ होला, यो वेबिनार चाहिँ रेकर्डिङ भइरहेको छ। सो यसको कारण चाहिँ हामीले वन्स रेकर्डिङ भइसकेपछि चाहिँ यो चाहिँ हाम्रो युट्युब च्यानल अनि सोसियल मिडियामा चाहिँ हाल्छौँ। सो इफ एनीवन वान्ट्स टु गो ब्याक अनि लिसन वाट द प्रेजेन्टर्स आर प्रेजेन्टिङ, यु कुड अलवेज डु द्याट। सो जस्ट वान्ट टु गिभ यु हेड्स अप सिन्स इट्स गेटिङ रेकर्डेड। यो वेबिनार चाहिँ अनि 1 घन्टाको हुन्छ, जसमा चाहिँ 15 मिनट्स चाहिँ हाम्रो स्पिकर आज चाहिँ डाक्टर पन्तले चाहिँ 15 मिनट बोल्नुहुन्छ। त्यसपछि चाहिँ हामी 10 मिनट चाहिँ क्वेसन एन्ड एन्सर राउन्ड गर्छौँ। अनि त्यसपछि चाहिँ हामी 10 मिनट्स चाहिँ ब्रेकआउट सेसनमा गएर चाहिँ कपल अफ डिस्कसन क्वेसन्समा चाहिँ हामी गर्छौँ र वन्स त्यो आइसकेपछि चाहिँ हाम्रो स्पिकरले फेरि हामीलाई ब्याक लिएर चाहिँ त्यो चाहिँ एन्ड गर्नुहुन्छ। अनि प्रेजेन्टेसन परि चाहिँ तपाईँहरू म्युट भएर बस्नु होला, तर क्वेसन एन्ड एन्सर राउन्डमा चाहिँ यु कुड अनम्युट योरसेल्फ एन्ड आस्क योर क्वेसन्स। अनि एट द सेम टाइम प्रेजेन्टेसन सकिनै पर्छ भन्ने छैन। इफ देयर आर एनी क्वेसन्स यु वान्ट टु आस्क अर्ली यु कुड जस्ट पुट अप इन द च्याट बक्स अनि हामीले चाहिँ मोनिटर गर्छौँ। विल ट्राई टु एड्रेस योर क्वेसन एज मच एज पोसिबल, तर यदि हाम्रो टाइम फ्रेमले भ्याएन भने एन्ड इफ डक्टर सगुन इज ओके यु कुड अल्सो इमेल डक्टर सगुन इफ देयर आर एनी क्वेसन्स द्याट यु वान्ट टु follow up with. So I hope that's okay with you, Dr. Sagun. Good. All right. I see a thumbs up. And yeah, most important, feedbacks are very, very important for us. त्यही कारण प्लिज हामीलाई चाहिँ अलिकति भए पनि टाइम दिएर चाहिँ हाम्रो फिडब्याक फर्म चाहिँ भरिदिनु होला। अगेन मेरो कलिग कृतिकाले चाहिँ फिडब्याक फर्मको चाहिँ लिङ्क पठाउनु हुनेछ च्याट बक्समा अनि त्यसमा चाहिँ तपाईँहरूले चाहिँ भरिदिनु होला। सो विथ द्याट आई डोन्ट वान्ट टु वेस्ट लट अफ टाइम अनि आई विल लाइक टु आस्क डक्टर ब्रान्डन कोट फर द इन्ट्रोडक्सन अफ डक्टर सगुन। So I'm just going to change the slides. I should have done this earlier, but yeah. these are all the things that I just said. All right, over to you.
Hasta subailai, namaskar. Suba Prabhat, Suba Diuso, Suba Patre, depending on where you are in the world and the time zone. I'm delighted to introduce Dr. Sagwan Pant. I've had the pleasure of collaborating with him on a number of projects in recent years. He has a very impressive track record already at this early stage in his career. Let me tell you a little bit about his work. So Dr. Sagwan Pant is a psychiatrist and a mental health researcher currently working as an assistant professor in the Department of Psychiatry at the Institute of Medicine, Kabila University. And he's pursuing his PhD at the University of Oslo. Dr. Pant works closely with people using drugs in Nepal and supervises health professionals and peer groups involved in opioid agonist treatment and rehabilitation services in Nepal. He's currently the SEAR representative at the board of NEPCAM, which is an organization of physicians in addiction medicine around the world. He has authored or co-authored 40 publications and won multiple international travel awards and fellowships. He's currently an adolescent substance use consultant at UNICEF headquarters and the mental health consultant at EPIC for key populations and people living with HIV in Nepal for FHI 360. Dr. Pant, let me turn it over to you.
Thank you, Brandon. It's a very humble experience to be introduced to you by you. So let me share my screen.
Sure.
Brandon has always been someone young researchers look up to, and he's played that role since early days in psychiatry. So not wasting any time. First question, am I audible? Yeah, sure. So I have 15 minutes to take you through my whole PhD work. Tough, but I'll try to make it as interesting as possible. So we talk about dual diagnosis and stigma among service users in opioid substitution therapy. My disclaimer is this is a part of my PhD project, and what I present during this session, especially the first part, is relevant to PhD work as a PhD scholar, and I have no conflict of interest to declare. For all of you that understand the situation of drug and substance use disorder in the world, opioid is one of the most problematic substances all over the world. About 61 million people use opioids globally out of the 284 million drug users in the world. So you can see it is common drug use disorder across the world. And even in Nepal, it is considered the second most common used psychoactive substance, excluding alcohol and tobacco, following cannabis. If you look at the trend of drug use in Nepal, especially the illicit drugs, so-called hard drugs sometimes, from a research perspective, there are three major landmark studies that have had last 13 years. First was in 2007, led by Ministry of Home Affairs, and which estimated around 50,000 people using drugs. So PUD is people using drugs, and PWID is people who inject drugs. So 60% of them were injecting drug users. And what was more problematic is a lot of them, about a third of them, are young drug users. The number increased by about 11% annum, 2013. 100,000 drug users. And the latest study, which I was also a technical advisor for, who estimated around 130,000 people use drugs in Nepal. About 30% of them are using injectable drugs. Predominantly of them are young, and the most problematic thing is a lot of them are drug users. You can see that opioid is more problematic than ever. For a lot of you, opioid is opium, commonly known as brown sugar, white sugar, heroin, smack, and all these street names. And opioid use management is not a traditional rehabilitation-based detox management. Over the years, there have been a lot of research across the world, and opioid agonist treatment, or also called as opioid substitution therapy, is considered as the gold standard for treatment dependence, and it actually includes prescription of opioids that is supervised by a medical provider and is supported by access to evidence-based psychosocial intervention. The World Health Organization, in its guideline for opioid management, says that detoxification is not considered the first line option when someone is a case of opioid use disorder. And it is wise and evidence informed to put them under opioid treatment. And the main goals of the treatment is that drug users die early, especially with opioid dependence. So it's to keep them alive, is to improve their physical and mental health. Opioid users are involved in criminal behaviors that includes drug trafficking, and kind of behaviors. So actually decreases that. And one of the most important assets of the OAT program is that it reintegrates the people using drugs into the society and improves their social functioning. So they can go job, school, college, support their family. That is why it is considered. In Nepal, this is still heavily funded by foreign investment. And currently we have around 14 sites across the country and is catering 100 service users. The resource, though limited, is ever expanding. And globally, if you see, despite OAT being a gold standard with an intervention with good level of evidence, globally, the OAT service users have reported lower quality of life, poor physical health, high prevalence of comorbid psychiatric disorders, a dual diagnosis, including suicide. And in Nepal, despite of this program being there, not much research had happened, and it was a good opportunity that I got. Dual diagnosis, also called co-occurring disorders. To just simplify it, if somebody has a psychiatric problem, simultaneously with a substance use disorder, it is called dual diagnosis. So if you see, a lot of people with mental disorders use substance use disorder as coping due to common disposing factors. The other way around, a lot of people with disorders have that are higher than general population, which includes mood disorders, anxiety disorders, post-traumatic stress disorders, suicidality, and other disorders. So this is something that was not taken into context in Nepal. And additionally, just focusing on Nepal, the stigma that disorder faces is already high. But you cannot imagine the amount of stigma substance actually face, because the society looks at them as moral failures, people that have failed the society, are useless, and are not able to support their country. And all of that stigma is actually internalized. Our drug user starts to believe on that. That is called internalized stigma. So my studies took a look at the stigma, which is considered as the stigma highest form. We'll talk about findings. So just to give you a brief framework of the modality, this was a cross-sectional study. We studied existing sites in Kathmandu, which was 2 in Kathmandu, 2 in Lalitpur, and 1 in Bhakpur district. 2 of them were government hospitals, 1 of them, and the remaining 3 were community-based sites. And a simple random sampling was done after the power estimation was done and the study. The key outcome variables, if you can see at the left side of my screen, mental disorders, which was screened, I'll talk about that later. Severe mental illness or serious psychological distress, alcohol use disorder, drug use disorder, coma, stigma, quality of life, and physical health and criminality. So the tools that I used for this study was BINI, which was used for the National Mental Health Survey, which I was again the advisor for. So I got permission from Dr. Sehan to use the tool, and then I used the tool. Then I used WHO Quality of Life Brief, which is commonly used for quality of life assessment, audit, the validated version, DUDIT, again, the validated version, ISMI, which was adapted for drug use context, semi-structured performer, which was designed to fit in a lot of parameters related to drug use disorders. Then we took an opioid treatment index, which was by Shane Drake, and this is an old, still valid for the components of criminality and physical health, and the very famous Kessler-6, which has been used for screening by laypersons in the past. This is the first publication that was done mid last year, and this was published in Social Science and Medicine, Mental Health. And then this study, actually the first publication, aimed at dual diagnosis among used opioid substitution therapy. And the main focus was on lifetime suicidality and lifetime depression, which was the most common findings. If you see towards the right side of the screen, despite of our service users being in an evidence-based intervention, so they're already into a treatment program, which is supported by evidence, the untreated mental health gap that was obvious in these clients were huge. So if we can see, 1 out of 4 had a lifetime major depressive disorder episode, 1 out of 4 had a lifetime suicide attempt, and about 1 out of 5 were concurrently using alcohol in the level of dependence in the last 12 months. And as expected, the social personality, which is usually associated with using drugs, was also found to be about percent in our study. So, and if you see the anxiety, if you consider all the components of anxiety, 3% was also larger than the general population. And the most common diagnosis, that is lifetime depressive disorders and lifetime suicidality disorder, lifetime suicidality, were studied further. We evaluated lifetime suicidality. It was higher among those with lifetime psychotic disorders, was higher among those with antisocial personality disorders, and interestingly, anyone that had a Kessler-6 score greater than 13, which meant they had serious psychological distress in the last month, were actually predictors of lifetime suicidality in future. So this was an interesting implication of the study, because Kessler-6 can be used by lay health workers or social workers or ex-drug users. And just using a simple 6-item, easy to administer tool was actually helping us predict lifetime suicidality. And that was an important implication of this study. And then the lifetime major depression was again associated with Kessler-6 score greater than the last 4 weeks. So this was one of the major outcomes or implications of our first study. Of course, there were so many interesting things which I cannot talk about, but I've just picked the major ones. The second publication, which again was published early this year, this went through a lot of reviews and to and fro, finally got published. And this study, I looked into comparison of quality of life and psychological distress among those that were injecting drugs and those that were not injecting drugs. As you can understand, people who inject drugs, the hypothesis is they have poorer quality of life. They are known to have physical comorbidities like blood-borne infections, HIV and hepatitis C and others. But there was not much from South Asian context comparing inject users and non-injectable users among their mental health comorbidities. And just to clarify, this is not current injectable use, because all of them are already into the OIT, not expected to inject. So these are based on past history of injecting. And what was interesting in this study was injectable drug users had higher serious psychological distress last 4 weeks compared to those that were injectable drug users. And those with serious psychological distress was associated with past quit attempts. So more the quit attempts, more the psychological distress, because that dignified failure of previous quitting attempts, past self-reported illness, and those with medical complaints. While when we looked into quality of life was poorer. Those with injectable drug use, especially in the physical domain, and those with the history of mental disorders and past quit attempts. So as we expected, quality of life and serious psychological distress were more associated with those with injectable drug users. So which implicates that the program should look into injectable drug users with a broader vision and other programs to address this. This is the third publication that is just accepted a week back in Journal of Psychosocial Rehabilitation and Mental Health. And this we looked into stigma. And again, internalized stigma, we used national stigma for internalized stigma for mental illness, which was adapted for substance use disorder. And what we did was we used this study to examine association of internalized stigma with factors like socio-demographic variables, quality of life, and common mental disorders. And we also examined domains of quality of life among those with high and low stigma. Just to give a short observation, despite being into treatment intervention, there was still a huge burden of internalized stigma. So about more than 1 in 2, every second, service users responded having high internalized stigma that was high across all 5 domains of the ISMI scale. And those with high internalized stigma, as expected, had lower quality of life across all domains. They had greater medical comorbidities, and they exhibited strong association with lifetime anxiety, depressive disorders, and alcohol use disorder. So it's the end of my presentation. So all in all, country has tried to address the problem of opioid use disorder with an intervention that is backed by evidence. But despite of it being into implementation phase over the last 14 years, there are issues of untreated mental health, unaddressed stigma, inability to address quality of life among service users. Of course, since this is a cross-sectional study and there were no control groups, generalization, my findings will have some questions. If I could. Other treatment programs, maybe people rehabilitation centers, but this project was able to showcase or project government that is heavily dependent on national funding and wish to have a program that's functioning well, that it is failing to address the mental health needs of people that are using drugs, and the interventions are not enough to address stigma. And we know inability to address stigma is a barrier. So I can send you the link to all the presentations. I still don't have a UI, which can be shared with all of you. And if there are any more questions, I'm ready to take one. So I think I finished on time. So up to you.
Thanks, Dr. Sagaran. That was an excellent presentation. 3 papers in 15 minutes. All right. That's the way to go. All right. So as I said before, we have 10 minutes for Q&A session. So I don't see anything in the chat box right now, but if anyone has any questions, please feel free to unmute yourself and start asking questions. Okay, so Didi कसैको छैन भन्ने. Okay, Ritika, you have it. All right. Ritika.
Thanks, Sawarda. I don't know how relevant it is, Dr. Shagun, but I just wanted to check what was your experience of using ISMI, the internalized stigma tool. If you had any experiences, what it was like.
Yeah, so apparently it was a mixed experience in that regards, because the tool that I had, which was translated by I think Sandhya Shrestha from one, which was used in previous studies and had a heavy mental health component, 9 items. Some of the items I actually had to sit down, do some focus group discussions, do some cognitive interviewing to actually modify questions that is more relevant for people using drugs, right? Some of them felt that some questions kind of felt repetitive, some questions feel mundane. But actually, ISMI, even in Brandon's previous publication, some publications have used just 10 items of ISMI, but I stuck with all 9 items. But in the end, came out was quite
Mhm.
exciting. And the other thing that is challenging us in ISMI is the Likert has 4 options, right? And when you score that, either it's yes or no. Either it's 1 or 2 will be scored as yes, 3 or 4 would be scored. Sorry, 1 or 2 would be scored as later, and 3 or 4 would be scored as yes. So with that rating scale, I think because I think we missed the middle part, Likert scale, you could have a different kind of observation. But again, for all of you that are thriving PhD, you get ideas when you are towards the end after publicating these things, because you think you could have done so many things differently, but that is what how it ended up.
Yeah, thank you, Dr. Shagun. And I think so Harda will mention towards the end of our presentation that towards the end of the webinar about our global mental health course. Yeah, things like these are definitely very, very interesting. And this could be like a broader conversation we had, because we had our own challenges with administering the tool as well. But yeah, thank you. Thank you for highlighting that.
Yeah, and I totally validate you, Dr. Sagun. At the end of your publications and PhD, you always feel you could have always done something differently. All right, so anyways, going to the next question, we have Renu up here. And like I totally agree with you, Renu. Always a pleasure to listen to Dr. Sagun. And also, she really wants to know about the relationship between substance use and trauma. So if you could speak a little bit about it.
Yeah, I think it's an excellent question. So there.
She has a follow-up question as well. I'll just
Yep.
let you look at the chat rather than me saying the same thing.
Also, given the intensity of pain, as you are mentioning, till diagnosis plus stigma, trauma, I see the need of extensive holistic treatment approach as a fight or war. How happy are you with the gaps in terms of help treating these patients? Okay, so a lot of heavyweight questions, but I think trauma is something that is being heavily studied amongst people using substance. So one of the things, as because I have this role as a clinician, this role as a researcher, as a clinician, one of the first things that comes to my mind is that the opioid intervention is this a patient or is this a drug patient? Because then the management implication is totally different. For someone, for example, I have a patient who has gone multiple surgeries for GI problems, and he has a colostomy in place. He was injecting fentanyl by himself for quite some time, but with not an intention of abusing drugs. He was managing his pain by himself. So that is a different implication. The OST somewhat suits that, or you have a different goals and mindsets to manage that. But when you look into drug users from substance use disorder perspective, that is more towards recreational, that is more towards use of drugs that started as a recreational use.
Dr. Sagun, can मलाई सुन्नु मैले बोलेको सुन्छ है?
Sunsa Sawarda. I think we lost Dr. Shagun for a moment.
I think that's the case. So, Dr. Sagun, so we lost you for a good, I think around 20 or 30 seconds. So if you could just repeat a little bit.
Okay, so I think, am I audible now?
Yeah.
So maybe something with the network. So just to keep it short, Renu, I can only say you that trauma is associated with substance use in 2 ways. One, they have a common predisposing pathway. So the other is people use substance to cope and adapt to trauma, right? So in that regards, in my experience with the people using drugs that I work with, I sense a lot of trauma in childhood experiences, adverse childhood experiences that actually come along. These experiences are related to parental experiences in schooling. Of course, this was not a part of my study, but then based on my experiences talking with them, they have a lot of intimate partner violence, a lot of trust issues, peer influence, being involved in criminal justice system, having to go to custody, if you see the research from Nepal, about 1 in 3 injectable drug users have been arrested during their course of using drug use in the street. So that adds on to the trauma. About your second question, I think, which is so broad, I can write a PhD on that again. But just to make it short, I can say that, as I said, first gap I would say is to address the comorbid issues like disorders and stigma that I projected in these studies. But there are also other issues like there is very few female participation. So female drug users are not accessing treatment because the level of stigma among female drug users are so many folds more. So there is no dedicated female treatment services, and there is problems with sustainability of funding, which is currently heavily dependent on the Global Fund grant. And with the HIV prevalence going down among injectable drug users, there are questions about sustainability. And the other problem is rehabilitation providers are not in line with the harm reductionist. So there are actually a lot of issues. I think I pointed out the major points. If not, we can again.
Thanks, Dr. Sagun. I'm just going to combine 2 questions. One is from someone from the University of Essex. I'm not sure what the name is, so sorry for that. I just see your email up there. And then another from KR. Again, like both of them talks about, question is on the stigma, on how, so KR's question is on how do we minimize stigma to address dual diagnosis, and then our person from Essex is more focused on the social stigma, right? So would you mind explaining it further? And then we have Brandon up next.
Yeah, I think the issue of stigma among drug users are twofold. So there's this double burden of stigma. There's this burden of stigma already that's imposed by them using drugs, and additionally the stigma they face because of other social developments, including mental health, just aggravates the situation. I think one of the best interventions to stigma, and that has worked, is to make these programs low threshold, so that they can actually come in, assess, and go back, and then to use PhD words to, train service providers to use the non-stigmatizing, better engaging. And one of the interventions in Nepal is like, you have your ex-drug users as service providers. So what that does is that increases participation, engagement, and again, we know participation and engagement are good for stigma interventions. What we have failed is we have failed to highlight champions that have actually survived drug use disorder using these interventions. If you can highlight these champions, project them as leaders or sources of change, I think that would be even more encouraging. And now we are actually working on interventions to find out people that are actually good brand ambassadors for people using drugs in the street. I think that is one modality. And the universal prevention approach of education, information, it has to be done, but you also need targeted and indicated.
Thanks.
And about the social stigma, I think there is a lot of prevailing social stigma, especially for people using drugs in Nepal. People heavily see them as people with moral failure, people that actually succumb to or maybe gave into the challenges that life threw to them, and so you actually see them as losers, which is not the case. So we are actually advocating and fighting for people using drugs and projecting them as survivors, not losers. I think that is how we change things.
Thank you, Dr. Sagun. Yeah, just talking about champions, one of the things that we have been working on in our current projects in Pokhara and Kaskil is also this idea of creating a champion among the primary healthcare worker, whom we call like an aspirational figures, to be the role model of someone like who can do things up there. So I think we just have time for one more question. I'm sorry, we can't fill in more. So Brandon has his hand raised for a long time. So yeah, over to you, Brandon. And this should be the last question for today.
Thanks so much, Dr. Sagun, for this really stimulating presentation. And as Saharda said, it was impressive packing 3 papers into 15 minutes. I'm interested from the policy perspective, given that you've now generated research on a number of these issues, how do you hope to affect policy in way with the actual data? And what advice would you give to kind of young researchers about transforming data-based findings into policy and practice?
Yeah, I think that's a very important question. There are broader implications in regard to, I could not show the findings, but then that we know that the goal of community-based organization, or maybe the funders, are only to enroll clients. But what this research effectively showed is enrolling is not helping them, because if you're not addressing the dual diagnosis, it will affect retention, it will affect maintenance, and we know that the opioid substitution therapy works best if these are continued for a good period of time, at least a year maybe, and then it has so many different advantages. So I think one of the policy reforms would be to revise the existing opioid agonist treatment guidelines to have interventions that are, better screening of substance use dual diagnosis, or better screening of comorbid substance use disorders, have measures to mitigate stigma. On that, I think in terms of there were other factors that came. The reasons that people were not, happy with the program was they were not getting takeaway doses. So imagine being a drug user and you have to come to this center day in and day out. Well, you may be motivated for 2 months, 6 months, but then it becomes too exhaustive. So I think one of the implications would be that there has to be takeaway dispensing that can work for about 1 month, or maybe if not 2 weeks. And the government has to think about sustainability. One of the things that's most worrisome is when this program started in 2006, around that time, the prevalence of HIV positive status among injecting drug users was around 50%, and now that has come down to 2%. The recent IBBS survey, the funders are not interested to look into this as an impactful interventions to reduce new HIV infections. So this study actually project benchmark for future investment and government priority support, because we have some findings that says that this is actually keeping them in and helping them.
Thanks. Thank you, Dr. Sagun. So as I said before, we are out of time for the question and answer right now, but there are a couple of questions that is in the chat box, and I think Barsa had her hands up. So if you want to follow up, we'll have Dr. Sagun's email at the end of the presentation, and please feel free to follow up with him. So with that, Dr. Sagun, I can start sharing my screen, and while Ritika is up on creating the breakout room, I just want to use a minute of the time to make a very quick announcement. So I think some of you have already seen this in our social media pages, in your email and all, but we are organizing the second Global Mental Health Assessment and Measurement Best Practices and New Direction course at the end of next month. That's in July. So the applications are open. So if you're interested, please feel free to apply. There are a set of criteria that's mentioned up in here. And this is the flyer for the course as well. And then Dr. Sagun, me, Dr. Brandon, and some of our colleagues here will be facilitating this session. So it should be super interesting, and also should be a good way to network with all the career researchers out there. So yeah, if you have any other questions, please let us know on this particular course. So with that, we'll go on our breakout session. So there will be 2 breakout sessions. One, Dr. Sagun is going to facilitate, and another, it's going to be me. And we have discussion questions up there. So Ritika, if you are ready, if you're ready, then I think we are all good.
Absolutely. I'm opening all the breakout rooms now. Just a reminder that the breakout room will last roughly 10 minutes, and then we will come back to the main room, and our speaker still has a couple of slides for us. So yeah, enjoy your discussions, everybody. I'm opening all the rooms now. Please join your breakout rooms. KRG, तपाईको room 1 मा हो. Can you join?
All right, so I think I'm 80जना मात्रै होला back हुनुभएको. So since the first question was yours, Dr. Sagun, I'll just let you do it first.
Yeah, so our group, I think Renuji, Tirendraji, Bolaji, interesting suggestions. So research needs go. Renuji comes from a background of trauma, and Wale saying drug use disorders are a broader intervention. Intervention, they say you common factors or predisposing factors or dual diagnosis or like trauma component like I think it's an excellent research idea. Trauma is known as one of the important predisposing factors. And our discussion somebody trauma interested by funder knock we should find funding sources. Then Bolaji important he talked about validated tools use measure right measure I think it's very important. Many a times we are measuring, but we're not sure what we're measuring. So especially substance use, because this is still a naive field. If we can have good tools to measure, which can be valid in our context, I think that would be one area of research. Then Dr. Dhirendra brought an excellent idea about having to do some research on cannabis, because cannabis use is really common nowadays, especially in Nepal, and he also experienced and that's why we're seeing a lot of cannabis-induced psychotic disorders. So maybe cannabis would be one area where a lot of research focus. And then overall, we thought if we can actually use assist, WHO assist when we do, just let's say subway drug use disorders are like परिकल्पना गर्छ त्यो भ्यालिडेट पनि गर्नुपर्छ त्यसलाई एडाप्ट गरिपुग्छ लोकल कन्टेक्स्टमा if you can adapt assist in our context, maybe we'll have a very good screening for all common psychiatric disorders. Our group say main key findings say over to you.
So our group was very interesting. So since the trauma I start from there. Anujaji, who's doing her bachelor's in psychology right now. Sorry, our question say like one research question on substance use and behavior disorder that's relevant in Nepal just for other group. Just Anujaji, since like as a Nepali, we have been through a lot of trauma in like different fronts. So doing something on trauma and substance use would be super helpful. So you have one more person on your team, Dr. Sagun and Renu, like who is also very much interested in trauma as well. He was more interested on looking at the long-term impact of substance use, just a family, or community, or more in nationwide, say, costo type would say effect a long-term effect, say, we discussed about that. And also one interesting kura say similar to what you discussed was about intervention as well. So is there an intervention that's culturally adaptable in the context of Nepal? And more importantly, say, can it reach like marginalized population as well? Layers so त्यो कुरा गर्यो अनि त्यसपछि हाम्रो So Narendra सरले चाहिँ he was very interested in तिनपानी त्यो लोकल रक्सीहरू हुन्छ नि सो उहाँको एक्सपिरियन्स चाहिँ गाउँघरतिर जाँदाखेरि चाहिँ लोकल्सले चाहिँ ए हामीले त लोकल रक्सी खाएको त्यसले केही पनि हुँदैन भनेर चाहिँ त्यस्तो धेरै सुन्नुभएको रहेछ सो वाट्स द डिफरेन्स बिट्विन हुन्छ नि तिनपानी दुईपानी खानु भर्सेस लेट्स से लाइक अदर हार्ड लिक्विड्स I don't know if I'm using the right terms, but अरू liquors खाने भन्ने कुराहरू गर्नुभएको थियो अनि finally हाम्रो Ankitaji was doing her master's in psychology ले पनि चाहिँ more if I'm saying it right more acceptance को कुराहरूमा पनि कुरा गर्नुभएको थियो जस्तै हाम्रो साथीभाइहरूले पनि कतिजनाले डेली खाइरहनु भएको छ अनि उहाँहरूले भन्दाखेरि not accepting होइन मैले त त्यतिकै गरिरहेको भन्ने कुराहरू so we talked about that अनि social factors को पनि कुरा गरेको थिए अनि I brought my own experience as well जस्तै मेरो culture मेरो ethnic group मा we use alcohol for almost every region like मर्दा जन्मिँदा खुसी हुँदा दुखी हुँदा we use everything up in there so त्यो कुराहरूले पनि how does that affect भन्ने कुरा चाहिँ it would be very relevant in Nepal भनेर चाहिँ हामीले चाहिँ त्यो discuss गर्यौं so we have a couple minutes more if I'm right Ritika so I'll again pass it up to you Dr. Sagun and let you summarize I know you have a couple of slides so I'll just let you do that
I think excellent research questions, excellent needs. I think the group actually summed up what we're trying to do. So, very I'm your diverse background. So, just to most of the slides, just much say key on a supply Nepal we something understanding education, addiction medicine, say clinical practice in infancy, very few people. Working full-time in addiction, at least no one able so body come when I'm just the game answer. So only jati publications are by that. So mostly they're focused on observational type of study. I think it's important. Observational study and it's like problem case the problem statement help studies saying जुन भएको छ त्यो पनि ट्रेडिशनल ड्रग र सब्स्टेन्सहरुमा फोकस छ जस्तै यो NHRC WHO ले स्टेप स्टडी गर्छ जसको फोकस चाहिँ अल्कोहल र टोबैको एज अ रिस्क फ्याक्टर फर NCD छ हैन अब हामीले चाहिँ त्यसमा फोकस गरिरहेको छ तर अब हाम्रो कन्टेक्स्टमा चाहिँ आई थिंक पोलिसी पेपर्सहरुमा पनि एकदम धेरै स्कोपहरु देख्छु म पोलिसी पेपर्स आर कमिङ अप वेयर वी कैन राइट अ पेपर मैले एउटा एडिटोरियल लेखेको थिएँ लास्ट 3 months ब्याक जुन राम्रो जर्नलमा पब्लिश भएको छ मैले नेपालको पोलिसी ग्याप्सहरुको बारेमा लेखेको छु सो पोलिसी पेपर्स इज अल्सो समवेयर वेयर कैन एक्चुअली स्टार्ट टु थिंक अबाउट लेख्ने एउटा कन्टेक्स्टहरु डेभलप गर्न सक्छ अब संसारमा ड्रग युजको प्याटर्न एकदम एक्सप्यान्ड भइरहेछ अहिले अमेरिकामा जहाँ सवारले बेस्ड हुनुहुन्छ त्यहाँ हरेक दिन नयाँ न्यू साइकोएक्टिभ सब्स्टेन्सहरु सब्स्टेन्सहरुले चाहिँ ड्रग युजर के अरे साइन्टिस्टहरुलाई जितिरहेछ मेडिकल प्रोभाइडर्सहरुलाई जितिरहेछ सो नेपालको कन्टेक्स्टमा पनि जस्तो लास्ट वीक चाहिँ मैले पोखराबाट आएको मान्छेलाई चाहिँ म्याजिक मशरुम खाएर साइकोटिक भएको केस म्यानेज गर्नुपर्यो सो इट्स कमिङ इन नेपाल हैन नयाँ खालको अहिले हामीले पार्टी ड्रग्सहरुको युज गेम सेक्सको चलनहरु अलिअलि स्टार्ट हुन थालिरहेको छ सो नयाँ खालको साइकोएक्टिभ सब्स्टेन्सहरुलाई पनि रिसर्चहरुले फोकस गर्नुपर्ने छ त्यस्तै ट्रायल्स मैले पबमेडमा की क्वेशन्सहरु राखेर हिट गरेको थिएँ त्यसमा चाहिँ तीनटा ट्रायल आएर तीनटा पनि यही ग्रुपको ब्रान्डन जी मार्क जर्डन भयो त्यसमा पनि स्पेशली सब्स्टेन्स फोकस छैन डिप्रेसन र सब्स्टेन्स डिप्रेसन र अल्कोहल फोकस छ र अरुमा चाहिँ सब्स्टेन्स इज वान स्मल पार्ट अफ बिगर ट्रायल सो प्रोबेबली नेक्स्ट बिगर स्टडीज प्रोजेक्ट्सहरुमा ब्रान्डन जी नरेन्द्र सर सवार्द एन्ड द टिम मेबी वी शुड think about other substance use constructs because this is so related to mental health comorbidities अर्को चाहिँ संसारमा अहिले तपाईको addictive behaviors कुरा हुन थाले छ internet addiction gambling disorders हाम्रै देशमा we see a lot of young guys PUBG addiction gaming disorders त्यसमा खै त हाम्रो रिसर्च के छ where do we stand म आजको जेनेभा WHO हेडक्वार्टर्स इन्भाइटेड छु 3 days मा alcohol drug use forum मा त्यहाँ चाहिँ अब हाम्रो ठाउँको रिसर्चहरुमा मैले प्रेजेन्ट गर्न खोज्दाखेरि चाहिँ सो लेस बेबल एडिक्सनमा त के रिसर्चै भएको छैन सो मेबी दैट इज वन मोर सो तर गर्न सक्ने कुरा धेरै छ र तत्काल हामीले के गर्न सक्छौं त कम से कम हाम्रो मेजर गर्ने हतियारहरुलाई चाहिँ चुस्त जुस्त पारौं सानो सानो प्रोजेक्ट्सहरु भ्यालिडेट गरौं मेजरिङ टुल्सहरु जुन हाम्रो कल्चरमा रेलेभेन्ट हुन्छ जस्तो नगेन्द्र सर हुनुहुन्छ त्यो अडिटमै पनि जुन प्रधानले भ्यालिडेट गरेको अडिटलाई पछि मोडिफाई गर्दाखेरि भ्यालिडेटेड टुलमै पनि कति कति फरक आउँछ भन्ने किसिमको हाम्रो एक्सपिरियन्स छ भने हामीले त्यो भ्यालिडेसनको एक्सर्साइजहरू गर्नुपर्छ। त्यस्तै इन्टरभेन्सनको स्ट्यान्डर्डाइजेसनको पनि हाम्रो उसमा कुरा आएको थियो, हाम्रो कल्चरमा एड्याप्ट गर्ने किसिमका इन्टरभेन्सन्सहरूको बारेमा सोच्नु पऱ्यो। मोटिभेसनल इन्टरभ्युइङ चाहिँ सब्सटेन्स युजमा नेपालको लागि कस्तो हुनुपर्छ त, मोटिभेसनल एनहान्समेन्ट थेरापी कस्तो हुनुपर्छ भन्ने किसिमका डिस्कसन्सहरू, त्यसमा रिसर्चहरू हुनु जरुरी भयो। र अर्को चाहिँ पर्सेप्सनको कुराहरू आएको थियो होइन, अघि कसैले भन्नुभयो ड्रग युजको पर्सेप्सनको बेस स्टडिजहरू हुनु जरुरी। र इम्पोर्टेन्टली आई थिङ्क वान अफ द मेजर landmark that we can do is we should focus, I think, on dual diagnosis. किनकि जो drug use disorder मा फस्नु भएको छ उहाँहरूको untreated mental health disorders छ र त्यसको इम्प्याक्ट चाहिँ उहाँहरूलाई सुसाइड यस्तो गम्भीर प्रकृतिका मानसिक रोगहरूले सताउने सम्भावना देखिन्छ। सो मेरो एक्सपिरियन्स चाहिँ people using drugs, I have met so many wonderful people that actually use drugs in life, so I don't want them to die untreated for very simple mental health. Personal questions छ भने मेरो email address छ, I would prefer Gmail मा पठाउनु भयो भने सजिलो हुन्छ, अर्को दुईटा मेरो institutional emailहरू हो। So thank you all for my time. I really enjoyed as a webinar. तपाईँहरूलाई कस्तो लाग्यो, and if you have any questions please write to me. I will try to reply. Thank you.
Thanks, Dr. Sagun. Ekdam interesting presentation, and I'm pretty sure audience are pani ekdam interested huनुहुन्थ्यो. So with that, this is the end of our webinar for today. So obviously next month we'll make the announcement pretty soon. So thanks again, Dr. Sagun, from all of us for such an excellent presentation. Very helpful. So yeah, thank you everyone. Ani good night. Bye bye.
Thank you. Thank you, Savarda. Thank you, everyone. Thank you, Dr. Shagun.